by Dr. TUSHAR BANDGAR. Our faculty, Dr. TUSHAR BANDGAR, is Professor and Head, Department of Endocrinology, KEM Hospital, Mumbai. He has been the principal investigator in more than 30 clinical trials in diabetes and endocrinology. To chair this topic, I call upon cardiologist Dr. Vineet Sinha and nephrologist Dr. Amar Sultan on stage. I request the chairpersons to please take the seat.
The hypertensive patients in and out before letting a patient has renal hypertension has renal parenchyma. The doubt always linger in mind whether I have reasonably ruled out other causes of hypertension. So looking forward to all those queries.
What do you say?
Hang off it. We need to look here and then talk. Yeah. So at the outset, I would like to thank IMA Akola, API Akola, Maharashtra Endocrine Society, and especially Dr. Anita Khandelwal for this opportunity. And I'm going to speak on endocrine hypertension. So we all know about the hypertension prevalence in India is almost 30%. And when we talk of secondary hypertension, it's always been thought of renal cause as a number one cause, followed by the cardiac, and endocrine hypertension. Usually we've been taught in MBBS days that it's less than 1% or 2%, and I mean, it's just really rare. So when we talk of endocrinopathies, we deal with this headings: thyroid disorders, pituitary, parathyroid, and adrenal. So most of the endocrinopathies will have a clear-cut clinical picture like this of primary hyperparathyroidism. They come with hypercalcemia and fracture, acromegaly, clear clinical pictures, hypothyroidism and hyperthyroidism. So when you pick this suspect and pick these cases, you treat these cases, the hypertension is really being taken care of. So what I'm going to talk about and generate discussion is about patients where you may not have clinical features in most of them, especially the primary hyperaldosteronism where they don't have any clinical features, and it's fast turning out to be the most common cause of hypertension, which I will try to showcase here. And the adrenal hypertension where you have increased mineralocorticoids leading to hypertension there, increased glucocorticoids leading to Cushing's syndrome, and increased catecholamides leading to pheochromocytoma paraganglioma. We will try to showcase these patients with the clinical pictures and how do we suspect and really screen these patients. Let's look at primary increased mineralocorticoid hypertension. So when we want to talk of renin, angiotensin, aldosterone system, the major players are renin and aldosterone. And when we talk of endocrine hypertension, it's low renin state always. So if you have a high renin or a normal renin or high renin state or a normal renin, then it's more of a non-endocrine cause you are dealing with. And if you have a low renin and high aldosterone, it's primary hyperaldosteronism. You have low renin and low aldosterone, it's a precursors which are there and not the aldosterone, and that's hyperdeoxycorticosteronism, and high renin and normal renin is non-endocrine causes. So let's look at low renin, high aldosterone, and primary hyperaldosteronism. So this is a case of Cohen syndrome, which was described by Dr. Cohen in 1950, where the patient presented with hypokalemic paralysis, hypertension, metabolic alkalosis, and the patient was cured after the adenoma excision, which was seen there. So when we talk of prevalence of primary hyperaldosteronism, this was studied by an Italian group where they looked in a primary care practice around 1,500 patients, and they did the PAC-PRA ratio in those patients. The prevalence was to the tune of 6%. So what we think is 1-2% of primary aldosteronism, it's not really the case. 6% of your hypertension is primary hyperaldosteronism, and as the stage of hypertension increases, you see the prevalence keeps on increasing there. And as guidelines tells us to screen for severe hypertension or resistant hypertension, but there are a lot of patients who are mild hypertensive also where primary aldosteronism is there, and we need to really pick this up. So though the guidelines tell you to look at severe cases, more and more experts are saying that in a lifetime of an hypertensive patient, at least screen that person once with a plasma aldosterone concentration and a PRA to rule out this particular cause, which is going to be a very, very common cause in this patient. So what we did was to look at prevalence of primary aldosteronism in our cohort at KEM Hospital. We screened around 500 patients of type 2 diabetes and hypertension with the classical criteria. We could find that 16% of the patient had screen positivity, and 50% of them were confirmed to have primary aldosteronism with a prevalence of 8%. So we are going to 6 to 8 and 10%, depends upon what kind of population you are really screening at. So I'll showcase one patient here, how do we really screen, how do we confirm, and how do we really manage and what is the standard of care which is there. So this patient who is 30-year-old hypokalemic paralysis and hypertension, when you know that there is hypokalemia, you need to think of hypoaldosteronism. You screen with aldosterone concentration and primary plasma renal activity. So this particular PRA is a cumbersome test to do. And now you have DRC which is available, which is a chemiluminescent based assay. So you can ask a PSC at DRC level, like a T3, T4 TSH, you get an answer within a day's time. And you can screen the whole lot of population of hypertension which you are suspecting that there could be PA there. What we need to know that this is endocrine hypertension, plasma renal activity is going to be really suppressed, and in the face of suppression of PRA, if you get aldosterone which is high, maybe 10, 15, whatever cutoff you decide to use, then you don't have to look at anything else and you really screen the patient for PA. And we are always scared about the prerequisites, that we need to stop the drugs which alter the ARR and all that. So in a clinical practice, you don't really need to stop all those drugs. Only prerequisite is that the patient has to be up and about in the morning, and after 10 a.m. in the mid-morning, then you make the patient sit for around 10 to 15 minutes and collect the blood for that. But because most of the drugs which you are taking will increase the renin. And if you get a renin which is suppressed on the screening test, your job is really done. You can go and interpret that. But if you still feel that there's a very strong suspicion, then you may need to do the drug kind of washouts for 6 weeks or 2 weeks, depending on what drug is usually there. So this lady we screened, aldosterone is 34 nanogram per dl, PRA is really suppressed, so diagnosis is really made there. So we need to do a confirmation test. Confirmation test has been done with a saline, seated intravenous saline suppression, where you infuse 4 liters of normal saline, 0.9% over 2 liters over 4 hours, and if the aldosterone is more than 6 nanogram per dl, then your diagnosis is really made for primary aldosteronism. So when you really prove that, then you need to say whether it's coming from one adrenal or it's coming from both the adrenals. Because if it's coming from one adrenal, you need to subject the patient to surgery. And if it's from bilateral adrenals, then it's a medical therapy which is there. And for that reason, we need to have an adrenal venous sampling. So this adrenal venous sampling is completely standardized, and we do it on a regular basis at KEM hospital with a VIR. And it's a daycare procedure. You need an intra-procedural cortisol to be estimated. What we essentially do is we pass the catheter to the adrenal veins, the right adrenal vein and the left adrenal vein, to confirm whether it has reached there based on the cortisol levels. And then we do 2 other ratios to see whether either of the gland, the right or the left adrenal gland, is secreting aldosterone. Based on if that particular gland is secreting more than 4 times that of aldosterone of the other gland, then your diagnosis is made. And we have some other ratios. So it's a typical daycare procedure. Patient comes in the morning and goes back in the evening. You can find out which gland is really secreting, and then you may decide to go for surgery. So you did an adrenal CT scan. You can see that there is an adenoma which is sitting there. Patient was subject to surgery, and this is yellow canary colored adenoma which is out, and patient is really cured. So it's really gratifying to see a curative cause of secondary hypertension, which is the message which needs to be taken from here. The things are not simple. We need some expert guidance here. So this particular lady, 52-year-old female, who's got resistant hypertension, hypokalemia, you want to screen for PSC, aldosterone is high, 18, more than 15 is abnormal, PRA is suppressed. You know this is primary aldosteronism. Confirmatory test done, more than 6 of nanogram of aldosterone, which confirms primary aldosteronism. We do a MRI of abdomen. See, there is a right adrenal adenoma and the left adrenal hyperplasia. And you don't know whether which gland is secreting and how do we really take that out. Then you subject the patient to adrenal venous sampling, and it tells you that the left one is secreting aldosterone and not the right adenoma, which is a non-functioning adenoma, based on those values which are there. We subject the patient to surgery, left adrenalectomy, and mind you, all these adrenalectomies are retroperitoneal adrenalectomy. So it's a process in which the patient goes for surgery in the morning, and by evening is able to walk about in the hospital. And within 2 to 3 days, patient can be discharged. You go from the back and not from the front. And that's a technique which we have developed at KEM hospital, because if you want to apply it to such a huge number of population 4%, 6% of your secondary hypertension turning out to be PA, then we need to have a procedure which is also that kind of feasible and practically possible. So we need to find out which is unilateral disease, because we need to subject the patients to bilateral adenotomy, or if the patient is not ready for surgery or it's a bilateral disease, then the medical therapy really comes into picture. So you've seen low renin and high aldosterone. Let's look at low renin and low aldosterone. Idea is to just sensitize you to show that such cases exist, and you may biochemically screen and think of these different causes. And these are patients from Vidarbha region only. Dr. Anita Khandelwal refers, Pramod Gandhi refers from Nagpur. So this is a patient. He was 37-year-old man, hypertensive. This is a younger brother. You can see he's short, he's dark, and he's got hypokalemia there. CT scan shows bilateral adrenal myelolipomas. We suspect, we know that it's a short stature with precocious puberty. Patient has got hypertension. So we do a plasma renin activity which is suppressed, aldosterone is low. We know it's precursor causing this particular problem. Do further hormonal tests to show that it's 11 beta hydroxylase deficiency. And patient needs surgery for these bilateral adrenal myelolipomas and needs treatment for the particular cause. So what happens is that in this 11 beta hydroxylase deficiency, this is adrenal steroidogenesis pathway. There is a block in the production of aldosterone. Aldosterone doesn't get produced, and hence your precursor starts getting produced. And they produce that hypokalemia and hypertension, and this leads to increased androgen, leads to precocious puberty. And that's how you need to just suspect that these cases do exist, and this is the cause of endocrine hypertension which really comes into picture. Now these two girls, both sisters, had hypertension at 17 years of age. She also comes with hypogonadism. So hypertension and hypogonadism and amenorrhea, think of an endocrine cause. They were 17 alpha hydroxylase deficiency. They were XY who did not, who had gonadal dysgenesis because of this particular part, and turns out to be 17 alpha hydroxylase deficiency. What happens is that there is a block in production of the androgens there, and there is decreased cortisol and androgen, and there is a precursor of mineralocorticoid which increases, and that's how you get into hypertension. So please think of such endocrine causes which are also there. So when we talk of increased mineralocorticoid, we need to just screen by aldosterone and renin ratio. Early morning, patient has to be up and about for 2 hours, collect the blood in sitting position for 15 minutes for plasma aldosterone and DRC. This can be done as a T3, T4, TSH in chemiluminescence assay, which is a message needs to be given. When we talk of second endocrine disorder, which is their Cushing syndrome. So Cushing syndrome is, most of the time they will have clinical features. You need to see them, suspect them. I will try to showcase you some patients where that really gives you a look into these patient photographs. So this is a patient who had mooning and plethora. This is pre-surgery and post-surgery. You can see the amount of mooning which improves after the surgery. So that's a kind of benefit you can get suspecting this cause and really treating them. This is a patient who's got catabolic features of skin with striae. You can see the mooning there, and post-surgery there's improvement. The striae don't go off, but it lightens and the patient improves quite well. This individual had myopathy and wasting with catabolic features of bone and muscles which improved with treatment. Here you have hypertension with pigmentation of the nails, pigmentation of the knuckles, there is edema of the feet. Post-surgery they improve quite a lot. So this is a kind of improvement which you can make in a patient's life if you really suspect these cases. And how do we really suspect them? It's a very simple test to be done. Cushing's you can get either because of pituitary tumor or an adrenal tumor or anything ectopic ACTH secretion. So as a physician, we are always perplexed about what is the overnight dexamethasone suppression test. Is going to be very difficult and all. It's a very simple test. You need to take 2 tablets of dexamethasone, 0.5 milligram at 11 p.m. in the night and collect morning 8 a.m. cortisol, serum cortisol. That's it. You got ODS suppressed. If it's more than 1.8, then your diagnosis is really made. So you've confirmed that there is a Cushing syndrome. Now we need to know where it's coming from. We do an adrenocorticotropic hormone level. If it's less than 10, that means pituitary is not producing it. And it's coming from the adrenals, we need to do a CT adrenals. If it's more than 10, generally there are some grey areas. We don't discuss the grey areas, we discuss simple things. More than 10, you know it's not coming from adrenals. So most common cause is pituitary, you image the pituitary. If is very high, more than 200, then you need to think of an ectopic cause for which you need to do a functional scan. That's what we usually do. So I'll showcase one or two patients where, so this lady who had a 29-year-old female who was on hypertension, mild DM, you could suspect that it was mild swelling. So mind if you comes in the OPD with 100 patients on your line, you won't really suspect that to look at the face. And you can't see that, global mooning and rounding and all that. There's mild hyperpigmentation of the nails, and this lady, we suspected that there could be Cushing's. ODS turned out to be 15.32, which is high. Did an ACTH was high. That means biochemically confirmed Cushing's, ACTH is high, it's coming from pituitary. You do an MRI pituitary, it shows that there is a pituitary adenoma there, and we subject the patient to transpleural surgery. It's a half-an-hour surgery. Again, 2 to 3 days admission, and there are expert pituitary neurosurgeons who just do a very good job and clear the tumor off. And post-surgery, they are cured. Another lady who had a similar kind of issue where you suspect. So unless you suspect that that Cushing's will be there, you may miss all these patients. So hypertensive, you do a ODS turns out to be high. ACTH is suppressed, less than 10. That means pituitary is normal. So we need to image adrenal, and this is an adrenal adenoma which is sitting there. You knock that adrenal adenoma, patient is completely cured. So these are curative causes of secondary hypertension which you suspect patient can be completely alright. So to summarize this part, so we've looked at increased mineralocorticoid hypertension, increased cortisol hypertension. How do you suspect that? Just do an overnight dexamethasone suppression test, 2 tablets in the night, dexamethasone 0.5 milligram, collect blood for cortisol in the morning at 8 a.m. If it's more than 1.8, diagnosis is really done. Let's look at pheochromocytoma, paraganglioma. Here also, a lot of times you can get clinical features, but a lot of times you may not really have clinical features. This is a case which tells you details about pheochromocytoma and paraganglioma. This is 13-year-old boy, abdominal pain for 2 months, hypertensive. Ultrasound then shows a mass there. How do we really screen these patients? So you do a plasma-free normetanephrine and plasma-free metanephrine. Plasma-free normetanephrine is really high, which confirms biochemically that there is pheochromocytoma. And post giving preoperative alpha blockade, patient was subjected to laparoscopic right adrenectomy, and post-operatively is doing quite well. So how do we look at these patients as pheochromocytoma? How do we suspect and how do we manage this patient? These clinical manifestations can be, they may be completely asymptomatic. They can come with an incidentaloma kind of feature where they just come with abdominal pain, or when you do a ultrasound and you can see the pheochromocytoma sitting there, or the patient can come with a catecholamine hypersecretion manifestation. So this young individual came with unstable angina, and you could see that there is a paraganglioma which is sitting there. This young male, 29-year-old male, came with sudden onset of headache and ptosis. This was because of the hypertensive emergency crisis with breast changes on MRI. This individual came in an emergency setting with hypertension and abdominal pain for 3 hours. Ultrasound showed a mass there. CT scan showed there is an evolving hematoma there, and the patient was subjected to urgent excision of the bleed in a pheochromocytoma, and we could save the life of this particular individual. You could have atypical manifestation like chronic constipation which is going on. This particular individual landed with subacute intestinal obstruction and had a pheochromocytoma which is sitting. So all these atypical manifestations also have to be really thought of when you are looking at the secondary hypertension. Most important part, 20% of patients with pheochromocytoma will have a genetic cause. So there are various syndromes you should be aware about. So when you take a simple basic medical history, you would be able to pick up all these cases. You cannot miss all these cases. For example, now this von Hippel-Lindau syndrome is the most common syndrome for pheochromocytoma, and you have these multiple manifestations. And they run in family. It's not that every individual in a family will have this manifestation. So one person can have pheochromocytoma, other can have pancreatic cyst, other person will have ENT tumor, endolymphatic sac tumor, some can come with renal cell cancers or cerebral hemangioblastoma. So they can go to multiple specialties, and just need to ask whether you have any family members who really have all these complaints or not. So by looking at this history, you may tend to pick up a lot of these cases. So I think last few months back, Dr. Anita Vandeva referred on VHL syndrome to us, a young boy with an hypertension. She did a genetics and it turned out to be VHL syndrome. So it's there, they're moving around in the community, they're not coming to the higher center. It means they have to be, they need to be picked up. So SDHH syndrome is succinate dehydrogenase syndrome. The SDHB is bad. Why it's bad? Because they come with multiple pheochromocytoma, paraganglioma, and they are malignant pheochromocytomas. SDHD, D is for dad. So it comes from father. So SDHD is there. So father has a carotid body tumor. Both the children, both the female daughters have carotid body tumor and a pheochromocytoma. So asking for this family history really helps to pick these cases. We have multiple endocrine neoplasia syndrome. Now this goes on for years. So patient comes after 10 to 15 years because things are not suspected and they land with emergencies. So she always had that cutaneous skin patch at the back, so which is itchy patches, and we don't really pay any heed to it. That's cutaneous lichen amyloidosis. Just need to examine that, ask for the history, and they have thyroid cancers which can go on for years, or they can come with metastasis for that. Meant to be clinical pictures. There's thick lips syndrome. It's called as mucosal neuroma, and all this part there, which can suggest that meant to be is there. NF1 syndrome producing adenoma. So learning point here is that we have stopped doing VMA, urine catecholamines and plasma catecholamines, and we have shifted to plasma-free metanephrine and non-metanephrine. Patient needs to can be checked any time of the day in the OPD. He needs to make need to make the patient lie down for 45 minutes and collect the blood for normetanephrine and metanephrine, no dietary restrictions and nothing else. So that can be done on an OPD basis. Important part, you need to do functional imaging to not miss multiple tumors. MIBG is not that good enough, and we shifted to FDG PET scans and rotatate scans, which will pick multiple tumors. I'll just show you a case where this has really helped us. This individual came with tinnitus and decreased hearing, where you had there was something coming out from the ear, and he had bilateral tympanic PGLs on imaging. So this picture was not complete. He was hypertensive also, and we did an FDG PET and rotatate scan, which confirmed it has bilateral pheochromocytoma and abdominal paraganglioma, and the treatment was PRRT. You can't keep on removing every tumor now and then. So you need to subject the patient to a multiple treatment modality which encompasses all the tumor part. 20% of the patients with pheochromocytoma have genetics positive. Please think of that. Therefore, family history is very important. And this was a study which we have done in 150 patients of pheochromocytoma, where we could get those percentages quite clear. If you have a family history, 100% chance. If you don't have a family history, 20% chance. So summarizing, you have plasma-free metanephrine to be asked for, and to summarize the whole talk, adrenal hypertension, PA is one of the most common cause of secondary hypertension. 8 to 10% of hypertension is a huge number. We need to screen them. You can screen them with plasma aldosterone concentration and DRC levels. Cushing syndrome, ODS cortisol is very simple test to do. And for pheochromocytoma, you do plasma-free, normetanephrine levels and metanephrine. If you ask for it, it will be available. It will be made available in your own city. I mean, you don't have to send this sample to Mumbai or Pune or anywhere else. With this, I would like to thank you for your patience.
Thank you, sir. I request the chairpersons to please express their views.
First of all, I would like to congratulate Dr. TUSHAR for such a nice and informative talk on secondary hypertension, basically endocrine hypertension. So, I would like to ask you, Dr. on day-to-day practice, whenever a patient comes to us, we diagnose it as a hypertensive, label it as a hypertensive patient. So, most basic question, when we should start suspecting secondary and more, I will say, specifically endocrine hypertension. This is the most important basic question. When we should start suspecting we are missing some kind of secondary, specifically endocrine hypertension.
So I think we need to ask for a family history. We need to look at clinical features. If your clinical features and family history are suggestive of any endocrinopathy, especially for pheochromocytomas and Cushing syndrome, definitely go and look at those ODS cortisols and plasma-free normetanephrine. But one of the important causes is primary hyperaldosteronism, where you will not have any clinical features. So if you say that there is hypokalemia is seen in only 30% of patients. 70% of the patients don't have hypokalemia. So unless you screen with PSC and DRC level, we will never be able to pick up primary aldosteronism, which is to the tune of 6 to 10% in our Indian population. So I think with clinical features and suggestive of endocrinopathy, look for that specific endocrinopathy. If you can't find it out, then please at least look for PAC by DRC, aldo by DRC ratio.
So, in my clinical practice, what I found, I am treating a patient, he is on 1 or 2 drugs, and suddenly his BP becomes uncontrolled. He is under my continuous follow-up for 2 years, and suddenly his or her BP shoots up to 200, and then I came to know, no, we have to go for endocrine workup, and it came out to be primary aldosteronism or Con syndrome.
Sure.
So these things, do it happen regularly? Suddenly there is surge in, and for 2 to 3 years the BP is under control.
Yeah. Sure, so it depends upon the
There
capacity.
are no clinical features of it.
So that's why we need to understand and accept that it really exists. First of all, right from MBBS and MD, it has been taught that endocrine hypertension is less than 1%. You don't need to think of it in a routine clinical practice. Now, first, if we accept that it's more than 5%, then we are dealing with a major issue. And once we accept that, we need to screen for that. Initial phases, as it goes for all hypertension, it depends upon the venous capacitance, where hypertension gets manifested or not manifested, and then you get into mild, moderate, severe kind of hypertension, depending upon the durations. So if you want to wait for catching the patient at severe hypertension, it's too late. You don't want to miss the bus.
Second question is regarding this pheochromocytoma. Which one is more important, normetanephrine metabolites or metanephrine metabolites?
So if to make a metanephrine, you have to go through normetanephrine.
Okay.
So if you want to be cost effective, you ask for only normetanephrine level, which will be 2,000 rupees. If you don't have cost issues, then you ask for both. It should be 4,000 rupees.
Thanks, sir.
Thank you. I request the faculty and the chairpersons to please proceed towards the center for after sedation.
Tushar, it was
And I request
one comment I would like to make for all our audiences as well. He made it very simple. If you want to screen for the endocrine hypertension, we have the things available with us in our OPD. We should do a ODS cortisol. That is very simple. In the night, you give 2 tablets of dexamethasone, and next day morning you can measure the cortisol level. Second important test is metanephrine, normetanephrine plasma levels, which are also very easily available. You can call any of these Metropolis lab or SRL lab people. They'll come to your OPD and collect the sample. We feel it is costly, but it is really cost effective. Like spending 5,000, 10,000, picking up one lifelong permanent cure for a patient, it is really worth it. Like it's asking for one MRI or a CT scan, and you ask for these blood tests. So always think about it. MRI or a CT scan, you are very pro. Okay, get these investigations done. When it comes to these blood investigations, we feel, oh, it's so costly, why to do it? We'll defer it. But no, we need to change our thinking. And third important thing is plasma this aldosterone revenue level. We feel it is only endocrinologists who get it done, but it is not so. So it's very easily available. Plasma aldosterone revenue level, no preparation required. Any time of the day, you ask them, please do aldosterone revenue level. And I'm announcing here, if any problem arises interpreting them, I'm available. Even if I don't see the patient, at least we can interpret the results and inform you, okay, who is to be referred and who is not to be. So let's start this in our practice. And today's take-home. Hello. Today's take-home message we imply in our practice. Thank you so much.
I request Dr. Suvarna Dole and Dr. Ashley Derrington to felicitate.
In any case of CKD or renal failure, it's difficult to interpret those tests. So for pheochromocytoma, the best way we can do is an ultrasound abdomen to pick up some cause, because the tumor needs to be at least 1 to 2 centimeters to really start showing manifestations of pheochromocytoma. So if you do an ultrasound or a CT, non-contrast, whenever there is CKD, you will not miss a pheochromocytoma. For PA, it's always a problem because you can't interpret your aldosterone
renin when renin is suppressed in CKD and renin is suppressed in CKD.
So, should we need a patient of creatinine of 1.8 and 2,
Yeah.
which comes with hypertension, you need to evaluate the secondary hypertension.
Yes.
Should we do all these metanephrines and PRA or should not be done?
I think PA, so aldosterone and renin will be a primary step to do. Doing metanephrine is a, first of all, it's a costly affair, and you need to have, you will not miss a pheochromocytoma. If you really suspected it, just do an ultrasound. You will not miss a mass, right? And small tumors are not to be really be bothered about. And then you can still go and do a 24 plasma-free non-metanephrine there. If it's normal, then it's all right. So milder CKD, it doesn't really affect. Severe CKD, you may have a bit of issues with estimation of the values. And that's where your imaging comes to your help.
Especially if he is hypocalemic. No, but I didn't get the answer.